no. I just want it like down a little bit. Perfect. Thank you. All right, awesome. Thank you. All right, good morning, everyone. Can everybody hear me? All right. We are ready to start. So, good morning, everyone. On behalf of the NIHHC, board members, and special guests, all the way from St. Joseph, Elkhart, and Kosciuszko counties, we want to welcome each and every one of you as we are here this morning for this highly sensitive but extremely important symposium on infant mortality to infant vitality. Infant mortality is the #1 indicator of well-being in the world. So why are we here this morning? Well, Elkhart County ranks among the top 5 counties in Indiana with the highest Hispanic infant mortality rates. Let me share with you some difficult but important numbers. In 2023 alone, 524 Hoosier babies lost their lives before their first birthday. That's about 44 babies every month, about 10 babies every week. Almost 2,700 infant lives have been lost in the last 5 years. Now that's over 37 school buses filled at maximum capacity. If we had the resources to educate expectant mothers, families, and providers over the last 20 years, Indiana's population would now be 10,000 people larger with additional children and young adults. Roughly speaking, that's a third of the population of Goshen and 20% of the population of Elkhart. If you look around you guys, that's 1 in every 5 of you. So, today, we all have the opportunity to focus on this challenging and sensitive topic, as it is not only our future, but our community. We also couldn't be here today without the help of some very special people. So thank you to the Indiana Department of Health and our sponsors, Beacon Health, Indiana Minority Health Coalition, First State Bank, Elkhart County Health Department, Community Foundation of Elkhart County and Building Strong Brains Coalition, Crossroads United Way serving Elkhart, LaGrange, and Noble counties, and Goshen Health. And now, I invite you to give your full attention to a short video we'll be playing to help you get a sense of what it really feels like to be the minority. Now, this video is in Spanish with subtitles, and I would please ask you to consider putting away your phones for this sensitive video. Thank you.
La mortalidad infantil es la muerte de un bebé antes de 1 año.
El índice de mortalidad en el condado de Elkhart sí es alarmante, muy alarmante. Me preocupa en mi caso, por mi embarazo. Es un embarazo por primera vez, es un embarazo de alto riesgo.
Cuando me enteré que estaba embarazada sentí mucha emoción, mucha felicidad, pero también miedo.
Tengo mucha emoción de que estoy esperando otra nueva bebé.
Fue muy feliz, pero también con muchos miedos por las pérdidas que tuve con la bebé. Tuve 2 pérdidas antes de ella.
Yo pienso que para una mujer embarazada, algunas cosas que son preocupantes puede ser, por ejemplo, si no tiene transporte propio, o a lo mejor si es una mamá soltera, si no tiene el suficiente apoyo de alguien que la pueda cuidar, acompañar, y también la preocupación pues de que su bebé esté bien.
El estrés laboral, la presión en casa, El hecho de que somos migrantes, los temas migratorios.
El no saber a dónde ir, cómo conseguir consultas, con que aquí las consultas son muy rápidas y no te dan la información necesaria. Te dejan con muchas dudas.
Hasta cuando nació, pues fue que me dieron la noticia que tenía el síndrome Down. Pues fue muy triste, muy duro.
La experiencia más bonita que yo he sentido durante este embarazo fue escuchar su primer latido, los primeros pataditas que te da y saber el sexo del bebé. Las visitas prenatales siento que son las más importantes porque es donde te están checando el bebé, que todo venga bien, que el bebé venga con salud, que todos sus órganos vienen formándose bien.
Cosas que nos ayudarían mucho durante nuestros embarazos son el hablar un poco más inglés, el tener acceso un poco más fácil a los servicios de salud médica, que los costos son demasiado elevados.
No tener miedo a preguntar.
Yo le pedí a Dios un bebé y me lo dio perfecto para mí. Para mí es la niña más hermosa que celebrando juntos tu primer añito.
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 Well, we have a fantastic event ahead of us today. Please note that the whole event is available in Spanish and English. We have our amazing interpreter with us, Ms. Uleja. It's also, if you guys notice the cameras, it's being broadcast live as we have virtual attendees. All the recordings and presentations are going to be available in English and Spanish in the next few weeks in our website. Now, I want to stress that your feedback to this event is very important, so you'll have the opportunity to evaluate it, each segment using the QR code on the back of your name tags. And to incentivize everybody more, we're going to be drawing for a $50 gas card after every presentation. You probably already noticed, but breakfast is outside to my right here. It'll be served there until about mid-morning. Lunch will be served in the same area until about noon. And then the restrooms are to my left here outside these doors. And then please find some time to reach the tables coming in this room, as we have some very relevant cultural resources that are definitely important to this topic. It is now my great pleasure to introduce you all to Dr. Lindsay Weaver. Dr. Weaver was reappointed Indiana State Health Commissioner by Governor Mike Brown on January 2025. She is dedicated to improving Hoosiers' health through prevention, access to care, and data-informed programs. Dr. Weaver leads Health First Indiana, which is a statewide initiative focused on prevention and strengthening local public health systems. Previously, she served as Chief Medical Officer for the Indiana Department of Health, where she played a key role in Indiana's COVID-19 response, expanding testing and coordinating vaccines. She is also an assistant professor of clinical emergency medicine at Indiana University School of Medicine, and she practices at Methodist Hospital. Dr. Weaver earned her medical degree from the University of Louisville and completed training at Indiana University. And most importantly, she and her husband have 5 beautiful daughters. So Dr. Weaver, welcome, and thank you very much for being here.
Good morning, everybody. Thank you so much for having me. Am I good? Do I need to do something on here, or just it'll be up here? They were worried because I sent them, I think it was like 87 slides for 45 minutes. But I talk fast. It's up here. There we go. That's fine. Perfect. Thank you. I believe in visuals. I think sometimes, you know, when you're talking about data, to actually see it graphed out for you is a good way of looking at things. I'm going to talk a lot about rates today, but where I can, I do want to put in the actual numbers because that's what matters, right? Those are the babies who have been affected, the women who have been affected. So bear with me with my data here. Oh, now we're not working here. Sorry, guys. It's not scrolling up here, it's on my screen. Now it's on the presenter screen on the. Oh my gosh, 1 second.
Technical difficulties.
I see your pointer.
There it goes. It's working. Yep. Okay. So at the Indiana Department of Health, our mission is to promote, protect, and improve the health and life of all Hoosiers, including those most vulnerable, our babies. So digging into infant mortality, as already shared with you, it is the #1 indicator of health outcomes. Why is that? Why would you look at infants to say that's your indicator of a health status across the world? And it's because they should be healthy. Moms are, younger, healthy, babies should be healthy. And so we know when we look at infant mortality, when you underline it, it is the health of the community that drives these outcomes. I'll show you some slides, but perinatal risk is the #1 cause leading to infant mortality, and perinatal risk is the health of the mom. Is she accessing health care? Does she have chronic medical diseases, smoke, substance use disorder? All those things are contributing to these outcomes. In 2023, the infant mortality rate was 6.6. So that means 6.6 babies died out of every 1,000 births. And just again to talk about what does that rate mean. So out of all the babies that were born in 2023, right? And then looking at all the deaths that happened in 2023, even though some of those pregnancies were in 2022. I'm also going to be showing you some geographic data. We based all infant mortality rates based on the location of residence. So we have some counties tell us we don't have a hospital, so how do you have an infant mortality rate on us? It is not based on that, it is based on the residence of the mom. As shared before, and I think that this graphic makes it stand out even more, that we had over 37 school buses at max capacity of infants who died in the last 5 years. And that is 524 Hoosiers, 44 babies every month, 10 babies every week, just in 2023. But I do have some exciting news. And you may have seen it recently in the news reported, but if I can get a drum roll, please. Our infant mortality rate for 2024 is 6.3, the lowest since we started collecting data in 1900. So kudos to all of you. We are making a difference. Let's give ourselves a round of applause. It's still not good enough though, right? But we have to celebrate the progress. If we don't celebrate the progress, we're going to be discouraged. So we have to celebrate the fact that we're the lowest that Indiana has ever been and that we're continuing to go down over the last couple of years. It is time to double down on the work. If my epidemiologist would tell me that if I don't say this, they'd be very mad. This is provisional, but we have continued to run the numbers over the last 4 months and it has remained stable at 6.3. Very, very slight possibility the final may tick up to 6.4, but it is still record-breaking for Indiana. And so this just kind of shows you the progress of Indiana. You can see where we are still significantly higher than the United States, which is that light blue line down there. But again, making progress. The US did go up, you can see there, in 2022 and 2023 for the first time in a very, very long time. All of this has contributed to the conditions around the pandemic. We now have a new birth outcomes dashboard that is interactive, so you can drill down to county level, all sorts of different factors, look at preterm rate, not breastfeeding rate, no prenatal care, moms on Medicaid, look at based on race and ethnicity, location, you can mix and match. We want this data to be available for every community because what is pushing and leading infant mortality does look different based on where you live, which is why it is so important to the State Department of Health that we are empowering the locals to make the change and do the difference. Because what you have to do here is going to look different than what they're doing down in Posey County, which is that very west-south corner there, if you haven't memorized all the counties like I have. Digging into looking specifically at race and ethnicity, you can see that our non-Hispanic Black babies continue to have an infant mortality twice that of Indiana and non-Hispanic white. And our Hispanic babies' infant mortality rate is 7, which is also higher than the Indiana and the non-Hispanic white infant mortality rates. I also want to call out the fact, this is my only slide that I have about it, but we are collecting hospital level data as well. Through our perinatal levels of care, all of the birthing hospitals in the state are submitting data to the Department of Health. We are giving that data back to them so that they can see how they compare to like hospitals. So just as an example, so you all know that we are also trying to drive this change at all different levels. This is the primary C-section rate. So this is moms who've never had a C-section before, that first time C-section. The goal for the nation is to get that around 25%. You can see that we're good there, but there is quite a variability between our different hospitals. So the hospitals don't know that unless we get them that information back. And so we are pushing that data back amongst many other pieces of information for them. So they are driving change as well. Looking at geography, so this is our health districts, and then that light blue is northeastern where we're at, but you should also look at that northern area. Our highest infant mortality rates are in our eastern and northern at 7.8 when we're looking across the state, and then you can also see here our highest Hispanic infant mortality rate is in the western part, but if you look at northeastern, it is 8.5. And so again, just differences based on where you live. And then digging in a little bit further, specifically District 2 here across the board, which is where we sit, and then District 3 should be looking at as well. And you can definitely see some variation. Also, so you know, we are able to dig down to zip code level. In some cases, in cities, we're able to actually get down to block level. We just have to have enough number to see that it is significant. And so here are your top 10 zip codes for infant mortality. The vast majority of them are Marion County or Indianapolis, but you can see number 2 there is St. Joseph, followed by LaPorte. So what is causing the infant mortality? I shared earlier perinatal risks. So, I always say kind of unhealthy mom, lots of things go around that, right? Like I said, access, good food, obesity, smoking, substance use disorder, et cetera, are leading causes of infant mortality. That's the dark blue there. Congenital anomalies are number 2, and then sudden unexpected infant deaths is that light blue there. The red is assaults or injuries, and green is other. And so you can see where our perinatal risks go up and down. That is what drives our change in infant mortality. So this, if we want to say where is our biggest bang for our buck, it is there, right? Followed by safe sleep practices. Breaking that down by race and ethnicity, again, you can see in where they have the highest perinatal risks numbers is where they have that much higher infant mortality rate. So again, non-Hispanic Black, twice the rate of Indiana, and then looking at Hispanic also a little bit higher there than the Indiana rate. If you see an asterisk anywhere in my presentation, that is just calling out that it is considered unstable because there wasn't enough deaths in there to say this is a statistical number. So I do want to highlight that. And then breaking down again, just kind of showing that change. So where we see the decrease here in infant mortality rate in our non-Hispanic Black babies was in that perinatal risks. There was a slight increase in congenital anomalies, but it has an asterisk there. So just to point that out. And then looking at non-Hispanic White, again, the decrease, you can see that in the perinatal risks. And then looking at our Hispanic infant mortality, significant decrease in perinatal risks from 4.8 in 22 to 3.6 in 23. So the work that's happening across the state to ensure that our moms get what they need and they're as healthy as they can be is working. This is sudden unexpected infant deaths. So this includes SIDS as well as accidental suffocation and strangulation in sleeping spaces. So this is kind of the catch-all, sudden unexpected infant deaths. But again, you can see a difference based on race and ethnicity. Looking at age, the majority of our babies are dying in the first month of life. Again, really driven by perinatal risks, preterm, and low birth weight babies. Breaking it down a little bit further, so that neonatal, that is that first month of birth, again, you can see primarily driven by perinatal risks. And then in that postnatal period, that is where you see the sudden unexpected infant deaths. And in fact, the majority of our sudden unexpected infant deaths are occurring between age 1 month and 3 months. So while it's important that we're having safe sleep conversations as moms leaving the hospital, but we also know moms thinking about a lot of things when they're leaving the hospital, it's that much more important that at those pediatrician visits, within communities, faith-based organizations, wherever mom is interacting with their community, those safe sleep messages are continuing. As we all know who have had babies or been around babies, that 1 in 3 months is a tough time, right? That lack of sleep is really kicking in. Maybe all the people who gather around you to help you right when baby's born have gone back, right, to doing other things. So just a really important time for us to be supporting families. And then just also adding here, it's not just mom and dad that need the education, it is grandparents, it's aunts, it's babysitters, it is the larger community. What are those big contributing factors to infant mortality? Obesity is something that we have to talk about. We know this does increase risk of infant mortality. It also increases risk of maternal mortality. So Indiana ranks 7th highest in the US for percentage of adults who have obesity. And we know 35% of Indiana births were to pregnant women who have obesity. And pregnant women who have obesity have an increased risk of preterm birth. 13.3% of Indiana births to those who have obesity were preterm compared to 9.4% who did not have obesity. Smoking is also a contributing factor, but I'll show you some great data that shows we're getting better there. 5.3% of births were exposed to smoking during pregnancy. Limited prenatal care, very important, and I know we'll be talking about that today. 26.6% of births were to women who were not receiving prenatal care in the first trimester. If you don't receive prenatal care in your first trimester, you have a 25% risk of having a preterm baby. That halves. It literally halves if they just have one visit, right? One visit, even not all the visits, just one visit really, really makes a difference. And then 18.3% of deaths in 23 were attributed to unsafe sleep practices. A little bit more about demographics. So the average age of moms with an infant mortality is 28.5 years. We also look at education, income, their insurance, and marital status. So lots of different ways of looking at the data to see, okay, how am I going to communicate? Who am I communicating to? What partners should be engaged here? What information do they have so that we know how we can support these women? Our teen birth rate has continued to go down over time, which is also very encouraging. And then looking at this here, you can see that our breastfeeding rate has gone up significantly in the last couple of years. Our teen pregnancy rate, as I mentioned, has gone down. Early prenatal care went down in 2022, but is back up again in 2023. And I know I mentioned our 2024 number. The team is now doing all of this work to get you this better data for 2024, and that'll come in the coming months. So I am still talking about 2023 data here, just to highlight that. And then breaking it down by race and ethnicity, specifically looking at Indiana, better everywhere except for preterm birth. Looking specifically at our Hispanic babies, better everywhere except for there was a slight increase in low birth weight. But really should be excited about some of these numbers and the improvements that we are seeing here. You can see that teen pregnancy is higher in our Hispanic, for our Hispanic babies, and then, but breastfeeding is the highest among all the race and ethnicities. How do we compare to the U.S.? I think this is something we talk a lot about, comparing different parts of Indiana, but we need to know where we stand looking across the U.S. And you can see we veered off in our percentage of preterm births here. The U.S. is the light blue, Indiana is the dark blue. So we have a higher percentage of preterm births. And then looking at percentage of preterm births based on race and ethnicity, again, significant difference there with our non-Hispanic Black babies, again, twice the rate. Looking at low birth weight, again, still pretty much on par with the US, so good information to know. But again, we see pretty significant differences here when we break it down by race and ethnicity. And then looking at specifically BMI, so that first column is low birth weight, and that second column, the third column is preterm, and the red is moms who are obese. So you can see when moms are obese, much higher percentage have low birth weight or born preterm. As I mentioned before, our smoking rate has continued to go down. We are now reporting that our vaping among youth has gone down. Earlier this week, I got to talk to our school nurses across the state, and I talked to them probably for, 5 minutes of my presentation about how they are contributing to improving infant mortality. Right, so if you get that middle schooler or that high schooler never to stop vaping, or never to start vaping, never to start smoking, then that is going to end up with a healthier mom, right, healthier baby down the road. So as much as we can continue to connect this work at every level, starting even with our youth, is where we're going to see these big differences and make a difference down the road. And then just looking at race and ethnicity again, over the years, our non-Hispanic white moms continue to smoke at a higher rate, but those numbers have gone down across the board. Low birth weight in preterm by smoking, again, just to highlight that we do know it is contributing, smoking is contributing to our preterm and low birth weight babies. And then you can see here we are closing the gap with our percentage of women getting prenatal care. And so that number or percentage has continued to go up over time, so that's good news. There was a national decrease, again, probably connected to the pandemic. And that red dotted line is our Healthy People 2030 goal. That's where we all want to be. And then percentage receiving prenatal care through the first trimester, again, breaking it down by race and ethnicity. And I think here to highlight that both our non-Hispanic Black and Hispanic babies have a much lower rate receiving that early prenatal care, which we do know leads to a higher risk of low birth weight and preterm, which are those yellow boxes on the bottom there. Again, closing the gap with breastfeeding. We're just below the United States percentage, so that's good, great work there. And we're still seeing some differences, but again, closing the gap where more and more women are breastfeeding. So in summary, 524 infants in Indiana died before their first birthday. The most recent number I had for 2024 is 508. So that's 16 babies. 16 more babies made it to their first birthday in 2024. While I do want us to celebrate that, we do know there's a lot of work to do, and I think the differences between race and ethnicity, where you live, access to prenatal care, all of these things are the places that we can all contribute. I do want to pause and give my summer PSA. We have a fatality review team at the state level. Every county also has a fatality review team that has to look at the deaths of our kiddos in the state. And about a month ago, my division director for our fatality review team said she and her team dread May because they know that they're going to start seeing drowning deaths. And every time I say it, it gives me chills, and that's how I felt then too, because these are so preventable. So this is your quick PSA. It is time to think about drowning prevention. It is the leading cause of death in kids from 1 to 4. Okay, leading cause of death is drownings. Nearly half of drownings are among infants and toddlers. The babies are often in bathtubs, and then those toddlers are in residential swimming pools, right? The thing that the kiddos can't wait to get to in the summer is a leading cause of the drownings. And then the teenagers, it's often in open water, creeks, ponds, rivers, lakes, etc. 2/3 of our drowning deaths occur between May and August. Boys account for 3 out of 4 child deaths. And like I said, most children who drowned, they drowned in swimming pools. And this is the most heartbreaking. Those kiddos were last seen in the home. They had been missing for less than 5 minutes and were in the care of one or both parents. It's just awful. I've had to take care of these families before. I have personal connections to a family who's been impacted. So your ask today, besides combating infant mortality, is also to go home and talk to your families and friends, especially those with pools and those community pools. What are we doing to prevent drowning? And then, of course, not all kids drown. We also have a high rate of near drowning that has lifelong impacts on those children. Here's a couple toolkits. So this is a water safety toolkit, just kind of reminding things that you can do. It's ndpa.org, and then the toolkit is available there. They have information for healthcare providers, for teachers, for parents, for babysitters, for lifeguards, so they have lots of stuff. And then this is a new campaign this year as well, which I'm excited about, from the YMCA. Phones down, eyes up. Who's guilty? I'm guilty, right? But what is our most precious commodity? What we're here to talk about today, right? Our kids. Okay, that's it for that. I did my PSA. Real quickly about Health First Indiana. So this was our huge investment in local public health. We went to the legislators and said, if you want to improve health outcomes in Indiana, we have to get into the space of prevention, and public health is where it's at. For every $1 you spend on public health, there's a $14 return on investment. And we have seen our health outcomes continue to get worse for many decades. And so this is where we need to put our time, our efforts, and our funding. In 24, our local health departments received $75 million. In 25, $150 million. This is up from $6.9 million a year for 20 plus years. So $150 million this year. Unfortunately, with the big deficit that our legislators were facing, budget deficit this year, it was cut down to $40 million per year. So it was 6.9 for 20 years, so 75, then 150, and then now it's 40. We need more funding in this space, so we're hoping that our budget forecasts and things improve in the next couple of years. And we do have heard from the legislators they would be interested in funding this more in the future. So just to kind of explain this funding, 60% of it has to be spent on preventative services, and it required all the counties to opt in, which we're thankful they all did for 2025. So all of our counties have received their part of $150 million. Why I wanted to make sure I talked about this today is that 10.8% of that was spent on maternal and child health, including funding grants for our community organizations. And then in 2024, almost 200,000 maternal and child health initiatives or services were given to Hoosiers. And specifically looking at Elkhart County Health Department in 24, they provided 23,000 maternal and child health services, including prenatal vitamins, safe sleep education, breastfeeding education and support. So again, this is those locally driven initiatives to improve outcomes. We are, of course, disappointed that we will not have as much funding next year, but we'll continue to work really closely with the health departments that we can do those services that make the biggest difference. And then just to show you the progress just in 1 year. So back in December of 2023, the green and blue counties are the ones that had initiatives to improve birth outcomes. And just by the end of 24, 84% of our counties had initiated programs to improve birth outcomes. We also have a lot of information here. This shows you infant mortality based on county, but you can also drive down obesity, smoking rates, other chronic diseases, overdoses, suicides, et cetera, again, to show where you're at in your community. We had set a state key performance indicator to get our infant mortality rate to 6.2 by 2030. So we're going to have to update this key performance indicator, because if we're already at 6.3, I think we're going to get there by 2030. So this is really exciting. This is the first time the state, the public health department, has set a key performance indicator, a goal like this. And we have this for diabetes, for obesity, for trauma and injury prevention, and now all of our counties have key performance indicators as well to hold ourselves accountable, and so you can hold us accountable to improving outcomes. And again, just showing you that significant change. If you go to our website, you can see what every single county is up to, who their partners are, what their local level key performance indicators are, and the activities in that community. Lastly, I didn't want to, oh, I'm going way too fast. Looking at infant mortality strategies, how do we decrease infant mortality? We're continuing to work with our hospitals on the AIM bundle, so hypertensive emergencies, hemorrhage, and substance use disorder, making sure we're screening moms and then getting them connected to care. Unfortunately, when we did a survey of hospitals, we found that many of them were, one, not screening for substance use disorder. We asked why, because we don't have anybody to refer the mom to. And they couldn't bear finding out that information and then not being able to do anything about it. And then those that were, about 25% of the ones that were screening, again, said, but there's nothing for us to refer to. So we do have our Pregnancy Promise program. So for any mom who is using substances, opioid or otherwise, you can call the Pregnancy Promise program and get them connected. They've had great outcomes there. To help moms work through their pregnancy and then afterwards as well. And then also we have our My Healthy Baby program, which is our home visiting program, specifically for moms who are on Medicaid. Depending on where you're at, sometimes there's additional restrictions that it has to be a first-time mom, but we're looking to expand that across the board as well. Our hospitals are conducting perinatal surveys again to make sure that the moms or the babies, our moms are delivering at the right hospital. So if it's a high-risk delivery, it needs to be at a higher level of care. Again, our goal that our moms and babies are at the best place for them. Other strategies, of course, Health First Indiana, that prevention piece, our home visiting programs that we have across the state, breastfeeding support, and infant safe sleep education. Continuing to do those reviews of our fetal and infant deaths so that we can look and see where could we have intervened to make a difference, and then again, helping our birthing facilities. And these are my very last slides. We did see a significant increase in congenital syphilis. 40% of babies with congenital syphilis are either stillborn or die within the first couple of days of birth. And the yellow is our babies born with congenital syphilis, and the blue line is moms of childbearing age, or women of childbearing age who tested positive for syphilis. You can just see this like exponential growth since 2020. Thankfully, we are on track that this is going down this year. So the work that people are doing in communities to increase screening has made a difference. Including the recommendation that all of our emergency departments are now including this in their group of STI testing. And if they have a pregnant woman that happens to show up in their emergency department, they're also considering this as part of their testing. Why? Because when we review some of these congenital syphilis cases, the OBs are telling us, well, they didn't get any prenatal care, but we look at their records and mom had visited the emergency department 2, 3, 4 times. right? So we have to start thinking about untraditional places that we can intervene and provide support. I am a practicing ER doc. I know how busy it is. It is not hard for me when my hospital helps me to set up a very quick, easy click, and it orders the gonorrhea, the chlamydia, and now the syphilis, also HIV and hepatitis C. Right, and then your health departments can help connect with the woman to make sure that she is treated. Also the men, right? We have to treat all the people, but this is something that where we can see a big difference. We can decrease infant mortality just in this space. And then again, we got lots of QR codes. We're continuing to try to make our stuff more accessible to all of you. So if you ever have feedback on our data or information, what we have available, please let us know. And I do have time for questions. Thank you. Oh, thank you so much. It's so sweet. Anybody have any questions for me?
I have a data question. Thank you. I'm Candy Yoder here with Building Strong Brains. We are struggling with collecting really good prenatal care access data in terms of when it begins. What is the source of the data you've reported?
It is from the moms. So this is when they're filling out that birth record sheet. Right. So we do really rely on our hospitals helping the moms to fill it out accurately.
One of the things we're finding is some moms believing that having a pregnancy test means they've received care.
Yep, yes, we have witnessed the same thing. We're getting better and better with this whole data thing. And so we also work really closely with Indiana Health Information Exchange, who does get information from most of the hospitals in the state, but not all. And so we're looking, how can we utilize that actual data? And I'll give you an example why I say actual data based on when you ask somebody. So there's BIRFIS, right, which is this national survey. It's a phone call survey where people are called in the state and they give information on their health. And we always guessed that our obesity rate was probably wrong and that people weren't reporting accurately on their weight and height and BMI. And so this year, for the first time, we were able to use actual data that we got out of the Health Information Exchange, and we were right. Our obesity rate is actually 10% higher than what had been reported, right? So until we start utilizing real data, that's when we're really gonna know whether or not we're making a difference. So that was kind of an easy one to start with, right? And then it's now getting a little bit deeper into the data, making sure we're asking it the right question. So really great question, thank you. What else? Anybody? Okay. Well, thank you, everybody. Appreciate your time.
Thank you, everyone. I wanted to remind you guys to help us completing this survey. It's behind your name tag. Another QR code. We are collecting QR codes here. And I think that we can take a little break now. We are going to come back for the presentation with Dr. Johnson at 9:50 back. But thank you so much. We are coming back at 10 in the morning. Thank you. Sorry about that.